Alright, so I'm a little late, like half an hour late, but I had an errand to run. Yesterday we finished up all of block 1 for NBME 23. It's a good block. Nothing was ridiculously crazy. There was a lot of variation in all the questions, but I think the unique thing that we picked out from block 1 yesterday were questions about these integral proteins. So the, I guess, basic science of knowing that a phospholipid bilayer, is hydrophobic stuff inside, hydrophilic stuff outside. So always remember that stuff. And now we're up to block 2, right? So let's jump right into it. As usual, keep in mind that NBME is a great tool to grasp concepts from, right? Because questions are going to look a lot like these first two. Very simple, straightforward questions with just a basic presentation of the patient, and then you have to figure out what's wrong with that patient. Just off of that, not much is given in NBME questions, and when a lot is given, like in question number 3, it's often a pretty weird, difficult question. Alright, and if it's even bigger than how question 3 looks, then it's usually a very easy question where they're trying to cover up the giveaway sentence by adding like 10 other sentences. So you really gotta pick and choose what you're gonna pay attention to. Okay, so let's get started. Number 1, a 28-year-old man. Let me just fit with. Okay, a 28-year-old man has hypertriglyceridemia that has not responded to gemfibrozil, which is a fibrate medication. Nicotinic acid therapy is started, and the dose is gradually increased to 3 grams a day. Which of the following drugs should be administered concurrently to prevent the most common adverse effect of this therapy? And as soon as you read that, you should think of how niacin has this side effect of causing a flushing, and it's a very different kind of flushing that it causes. So if we go back and look at it, it's page 340. Alright, so if we go back and look at it, you have to remember niacin kind of works like a statin, in the sense that, the effect it causes are similar to a statin. Right? So niacin, you can see it lowers LDL, increases HDL, right? And it lowers triglycerides. So you can see how it's relatable to statins, but completely different mechanism, of course. So niacin, it inhibits lipolysis by inhibiting hormone-sensitive lipase, right? And you have to keep in mind, hormone-sensitive lipase, this is the guy that's more so relevant to stress moments of high stress. Maybe you're starving, maybe you have really long work hours, stuff like that. So taking niacin is done in the way they described it in the question, right? So they described it as starting at a low dose and then gradually increasing it to 3 grams a day. That's how you do it. Now, it is possible to have this red flushing that happens, but you can reduce that by taking NSAIDs, right? So take aspirin. That's it. Other than that, niacin can also cause hyperglycemia and hyperuricemia. So it's not a preferred treatment for someone who might be prone to or have diabetes, someone that has diabetes, and someone that might be prone to gout. Right? So avoid niacin in those patients, of course. I wrote over here information about fibrates and niacin, so you could tell that they are often taken together. Fibrates upregulate lipoprotein lipase, LPL, right? While niacin inhibits hormone-sensitive lipase. Really important to make sure you remember the difference. So if you take the two medications together, you'd be working on 2 different targets, and you can kind of tell that it's really helpful, right? If you combine fibrates and niacin, you can see they both lower LDL, they both increase HDL, and then fibrates heavily help you reduce triglycerides as well. Right, so it's kind of like, imagine if you could actually take statins and fibrates together. That would be the dream, right? Because statins heavily lower LDL, fibrates heavily lower triglycerides, but you can't take them together, right? Because they both cause myopathy. So the get around to that is taking fibrates with niacin. So it is a common thing, and this question is very realistic. And aspirin is something that all of us are going to be taking one day. It's the most commonly taken medication on earth. So that's what you do. You take aspirin with niacin and you avoid that flushing. Really straightforward. Niacin works by inhibiting HSL and reducing hepatic VLDL synthesis. Really important to remember these mechanisms, because you do get tested on them, and oftentimes when you read the mechanism, reduce hepatic VLDL synthesis, that might look like, it's not the correct answer, but it is. You have to make sure you remember that. Number 2, an otherwise healthy 26-year-old scuba diver has difficulty breathing immediately after ascending from a 30-minute dive to a depth of 15 meters. which of the following physical signs is most consistent with the X-ray of the chest shown? Right, and then you look at the X-ray, and you have to practice looking at X-rays. It takes a while to really get good at it. You have to understand that when you look at X-rays, there are a bunch of things you're supposed to check for. And I haven't done the new respiratory videos, but that's going to make you really good at it, because the new respiratory videos are going to have the AMBOSS images, and AMBOSS is brilliant for respiratory. They have these X-rays where they kind of highlight what you're supposed to be able to see. So for example, when you look at an X-ray, you should be able to see the claustrophrenic angle. That's definitely something you want to make sure you can see. Okay, that angle right there, that angle right there. You should be able to see it really, really clearly. Otherwise, that might, if you can't see that angle, that means there's some fluid here. So that might be a sign of pleural effusion. We don't have that in this patient. And then this area right here, the hilum, right? Remember that patients can have hilar adenopathy, and some patients can even have bilateral hilar adenopathy. We don't necessarily see major bilateral hilar adenopathy, but this is pretty prominent. I can kind of really see that. Other than that, all I'm noticing is that the lung is really big, right? You can tell that it's like really full. It's completely full of air. So, if it's full of air like that, and this patient has difficulty breathing, and this patient was under a high pressure, right? That's what you have to understand. So this patient was under high pressure, came out of the water, and then all of a sudden couldn't breathe anymore. So there was some kind of pressure change that caused what was most likely a pneumothorax, right? And if you look at this is an X-ray that just looks like there's a bunch of air. That's why everything's black. Other than that, I don't see any major issues. So all you would expect on physical finding is hyperresonance, right? Resonance is mostly going to be related to having too much air in the lung. So hyperresonance over most of the left side of the chest. What you're supposed to see on the left side is that the lung has kind of collapsed. That's how the lung is now. That what I outlined right there. Let me use a different color. Yeah. So the lung. Oh, too fat. Is that better? Still too fat. The lung is kind of tiny now. That's that outline that you're seeing. That's your new left lung. So all of this is just full of air from the pneumothorax. Okay, and you can catch that. You can see that because you see this line is very, very clearly visible right here. You don't have a similar line on the other side, right? So this patient's lung, this patient's lung, the left lung collapsed. That's kind of what happened there. And then knowing lung sounds is really, really easy. You want to make sure you master that. If anything, master it today. Memorize all of that today. Let's take a look at that chart for the heart sounds. What page did I have written? 754. Okay. So here they tell you, breath sounds, percussion, fremitus, tracheal deviation. This is the first aid chart that they give you. And then let me see, where's the other one that I have? There's a U-World chart too. Okay, if we look at this first though, if we look at the one that came from first aid, right? Breath sounds, yeah, I don't per se like this one too much, but okay, we can look at this first. So when you do percussion or when you do tactile fremitus, right, both of those things tell you a lot of stuff. When you think of percussion, think of percussing the strings of a violin, something like that, right? So you can't hear an instrument playing if there's no air to transmit those sounds to your ear. So if you hear a lot of sound from percussion, there must be too much air, right? And that's kind of what you see in a pneumothorax, right? Pneumothorax has too much air, so you get hyperresonance. Fremitus is only high when something solid is there. Tactile fremitus, you want to think like knocking on something solid, like that, right? So tactile fremitus. So if you're knocking on something solid, you hear a louder tactile fremitus, and you could tell the only time tactile fremitus is high is when you have something solid, right? So consolidation. I know it's not completely solid, but that's how I remember that. Okay. So consolidation, such as lobar pneumonia or pulmonary edema, all of these are going to be scenarios where you have increased tactile fremitus. So high tactile fremitus, consolidation. High percussion, too much air. pneumothorax. That's it. Those are the two main things. Now, everyone runs away from tension, right? We all avoid tension. So tension pneumothorax is the only time where your trachea deviates away from the side of the lesion. All right. Whereas in a simple pneumothorax, there will not be any tracheal deviation. So those are the lung findings that first aid talks about. There's another chart that I got from UWorld. Let me see. I should be able to find it. No, not that. Like, I had to add so many pages into the respiratory chapter because there was so much more to know in terms of, oh, okay, right here, pulmonary auscultation examination findings, right? So this is another table. Let me put this page here too. Okay, just so I have that there. This is another table that does a really good job by straightforward showing you, breath sounds, tactile parameters, and percussion. This one doesn't tell you about the tracheal deviation, but the only deviation you really need to remember is tension pneumothorax. You deviate away from the lung that collapsed. So here, what they tell you, in a normal lung, obviously you're going to have normal breath sounds, normal tactile parameters, whatever that's supposed to be, and there will be resonance when you do percussion because there's air in the lung. It just will not be hyperresonance, right? The only time you have hyperresonance is in a pneumothorax, okay? And when you do tactile parameters, it's always decreased in any of these other guys. It'll only be increased when you have consolidation, right? So the main takeaway points are really just this one here and this one here, right? Those are pretty much, I guess, diagnostic in a sense. They help you figure out what's wrong. So always make sure you're able to kind of grasp that from a question, right? And in this question, they wanted you to pick what the correct sound you're going to hear is, and it's going to be hyperresonance. It's going to be hyperresonance on the left side, specifically because this lung collapsed, right? Number 3, a 60-year-old woman with type 2 diabetes comes to the office because of a 6-week history of right shoulder pain. The pain occurs when she attempts to raise her arm and when lying on her right side. She has not had weakness, tingling, or numbness. Physical exam shows tenderness to palpation in the region of the right deltoid muscle, just lateral to the acromioclavicular joint. While sitting upright, she is able to abduct her arm to nearly 90 degrees, but additional abduction is prevented by pain. Muscle strength is 5 out of 5 in the right upper extremity, sensation is intact, and there is no impingement sign. So when they say there's no impingement, right, as soon as they tell you there's no impingement, you can knock out rotator cuff tear, rotator cuff tendinitis. Right? We saw a question in block 1 yesterday where the impingement was a rotator cuff muscle. More specifically, it was the supraspinatus. So if we go to upper extremity. Right here. Right. So when you look at your rotator cuff area, right? The acromioclavicular joint is going to be like right here because you have your clavicle here. So this is where they're talking about. If you had impingement or anything like that, right, then it would probably be the supraspinatus. This muscle gets impinged the most commonly. A most common rotator cuff injury, but this patient doesn't have a rotator cuff injury. They also told you she's able to do the abduction up to 90 degrees. So the supraspinatus is working, the deltoid is mainly working, even the trapezius is okay, and something must be wrong after that, and it's preventing her from doing more, but her muscle strength is okay, everything else is fine. So then you look at all your answer choices, right? The last thing they said was, and sensation is intact, so the axillary nerve is working too. Right, remember that the axillary nerve is kind of responsible for sensation around here in your shoulder. Right, so everything's fine in that aspect too. So there's really nothing to pick in terms of muscles for that question. So now you start looking at your answer choices: adhesive capsulitis, bicipital tendinitis, Pancoast tumor. You can knock that out too. It's not a Pancoast tumor. A Pancoast tumor would mostly be up here, not affecting the shoulders per se. So now you're really left with A, B, and F, right? And here the answer was a subacromial bursitis. And the reason you would pick that is because they told you that the involvement of the acromioclavicular joint, right? So that's why it's subacromial bursitis. Basically, she has a bursa under her acromion, and it's kind of preventing her from abducting her hands any more than 90 degrees, and it's hurting. That's it. All right, so I wrote here, this is not B, C, D, or E, because those would not present in the manner that she's presenting. Adhesive capsulitis is frozen shoulder, right? Frozen or glued shoulder. That's why the word adhesive, you always want to think of adhesive as glued shoulder, where the connective tissue around the glenohumeral joint becomes inflamed and stiff, greatly restricting motion of the shoulder and causing pain. So she wouldn't even be able to abduct her hands up to 90 degrees. This patient has a subacromial bursitis, where the bursa separating the supraspinatus tendon and the acromion is inflamed. Hence, the patient presents with supraspinatus type issues of the difficulty with overhead work, right? But it's not a supraspinatus issue because they told you that muscle strength is fine and there's no impingement. All right, that's kind of how you were supposed to work with that. So here I did put a picture of the adhesive capsulitis, since that NBME mentioned it. Right, so you can see how everything's just become really stiff, and she will not be able to reach up at all. It's going to be really difficult. No abduction for that patient. Next question, number 4. A 36-year-old nulligravid woman and her 40-year-old husband come to the physician for genetic counseling prior to conception. They have no family history of genetic syndromes. They have been reading on the internet about certain inherited diseases and ask about their risk for being carriers of an autosomal recessive neurodegenerative disorder that occurs in 1 in 10,000 individuals. Which of the following best represents the carrier frequency of this condition? Okay, so this is just straightforward Hardy-Weinberg stuff, right? They told us that the prevalence is 1 out of 10,000. Okay, so P squared is 1 out of 10,000. That means P is 1 over 100 and Q is 99 over 100. Now we need the heterozygote carrier frequency, which is 2PQ. So 2 times 100 or 1 over 100 times 99 over 100. And you can kind of estimate 99 over 100 to just be 1. So it's really just going to be 2 times 1 over 100, which is 2 over 100. That's 1 out of 50. That's it. It was just straightforward Hardy-Weinberg. No crazy genetics or anything like that. You didn't have to do any intense work, right? Take the number they gave you, assign it to a certain variable, then find all the other numbers. That's all you have to do. Every time you get questions like this, they'll give you one of the things from P and Q. Find everything else, right? Maybe they'll give you P squared, maybe they'll give you Q squared, or 2PQ, whatever they give you. You should be able to utilize it to find the rest and then work from there onwards. So this was just one out of every 50. Okay. Number 5, a 2-week-old female. So this is a really long question. A 2-week-old female newborn of Mexican descent is brought to the physician by her mother for a well-child examination. The mother reports that the baby has been doing well, except that she often cries inconsolably for about an hour after feeding with formula. The mother says, I am sure that she has got the evil eye. The mother has been passing an egg over the baby's body, then cracking the egg into a glass of water and placing the glass underneath the baby's bed regularly. However, there has been no change in the baby's behavior. So basically the mother is doing something very superstitious, possibly religious. The newborn is at the 50th percentile for length and weight and 35th percentile for head circumference. Her vital signs are within normal limits. Physical and abdominal exams show no abnormalities. Which of the following is the most appropriate statement by the physician? So if you look at everything now, generally speaking, for questions like this, you should practice looking at questions like this where you just read all the answer choices first, and immediately you know this question scenario isn't even needed. You just look at all your answer choices and you already know which one of these is like actually okay for any physician to say in the first place. For example, imagine we hadn't read the question yet. Answer choice A, have you considered talking to a faith healer to see if there might be other measures you should try? Now, a doctor is never really supposed to recommend a faith healer, so A would not be the correct answer under any circumstance. B, I think your baby has gas, not the evil eye. Why don't we try giving her medication? Very plausible. I can see how that's plausible. But remember, yesterday we talked about the fact that when you take ethics questions like these, you always have to remember that people are very sensitive, right? Very sensitive. So as soon as you say something like that, your baby has gas, not the evil eye. Like, why the fuck are you doing superstitious shit? That's what she's hearing. Remember, sensitive people hear more than what you just said, right? So when this doctor said, I think your baby has gas, not the evil eye, we should give her medication, the sensitive parent might hear you say something that would come off as condescending, insulting, disrespectful, blah blah blah. It's really, really annoying when they do that. But matter of the fact is, you can't talk like that. You just can't. Right? So, but again, plausible. That is kind of what you might actually be thinking. The second point I had made about ethics questions was that it's not about what you think is right. It's just what's actually correct, right? And that's also something that is difficult, and it comes with practice. C says, I'm not very knowledgeable about your folk beliefs. Would you like me to refer you to a doctor who is? Again, unnecessary. The doctor does not need to share the patient's folk beliefs. Like, it doesn't matter. It's irrelevant to the treatment. D, there's not a lot of evidence in modern medicine to support what you're doing, but it isn't harming the baby. Again, the topic of this question is not going to be about what the mother's doing, in terms of, for D, you would have to read the question, and we would know that, the mother's been doing this superstitious egg thing and cracking the egg. It's not harming the baby at all, but that really doesn't solve the problem. E, why don't you continue with what you're doing, and let's try changing her to a different formula. That sounds like the most plausible thing to go with, right? Because one, you never want to tell someone to stop practicing their superstitions, their religion, whatever it might be. And two, changing the formula actually does seem like a very intelligent thing to do. The baby is actually okay. There's nothing significantly wrong with the baby. When you see statements like this, though, this often throws people off, right? The baby is at 50th percentile for length and weight, 35th percentile for head circumference, but those are not things that tell you that the baby is not developing well. Okay, you can kind of think about it like maybe when you were in high school, you might have had an average of 65, but that didn't mean that you were mentally ill or anything like that. That's just how you were, right? So this is how this baby just is. It's okay. It doesn't show that the baby's not growing well. I mean, sure, the baby could be growing better, but this doesn't seem like any pathological thing, right? So it's a very difficult and very fine line to that too. So be very careful. But in general, this is, like I wrote here, dumb as usual. Even choice D does not sound so good, but yes, changing the formula would be a fine thing to try, so E is the best answer here. Right? But again, it's a pretty difficult thing to understand where the ethics questions are in terms of like picking the right answer choice. So you really just have to go with what you truly believe is completely flawless. And saying what's in answer choice E is flawless. Number 6, an 18-month-old girl is brought to the physician because of failure to thrive and frequent wet diapers. She's at the 3rd percentile for length and weight. Physical exam shows dehydration, decreased muscle tone, and bowing of the legs. Just to pause, these two sentences, right? She's at the 3rd percentile sounds so bad, but what gives you more information than that sentence is the next sentence after. Physical exam. That sentence, and no matter what question you're doing, that sentence always tells you the most information. And the bowing of the legs is kind of making you think of like maybe a vitamin D deficiency. Slit lamp exam shows crystals in the corneas, and the slit lamp stuff should tell you exactly what's wrong as soon as they mentioned it. Serum studies show hypophosphatemia, hypokalemia, and a non-anion gap metabolic acidosis. Urine studies show a pH of 5, glucosuria, phosphaturia, and generalized amino aciduria. Which of the following is the most likely cause of the metabolic acidosis in this patient? So it looks like the entire PCT is not working, kind of like Fanconi syndrome, because she's peeing out everything, and she's got hypophosphatemia. So you look at all your answer choices, and F is the one that says the correct reason for why she could possibly even have metabolic acidosis. Remember, there's two ways to answer this question. One, you pick what actually makes sense for the patient, and then two, which one of these even cause metabolic acidosis, right? And if you have decreased sodium bicarbonate reabsorption in the PCT, that does both things. It fits the fact that her PCT is not working, and two, it fits the fact that that would cause acidosis, all right? She has loss of vitamin D, crystals in the cornea, low phosphate, low potassium, metabolic acidosis, glucosuria, and loss of amino acid. Most of these are reabsorbed at the PCT, so something is wrong with the PCT function. Bicarbonate is also reabsorbed at the PCT, so F makes the most sense, and this patient most likely has Fanconi syndrome. Right? Renal tubular acidosis type 2 is a defect in the PCT bicarbonate reabsorption, which leads to metabolic acidosis. renal tubular defects include Fanconi syndrome, right? And Fanconi can lead to RTA2, just like we put up here. Fanconi also loses PC2 function. So either way, it could be any of these things. Regardless, we didn't need to know what she has. We just needed to figure out what's causing her acidosis and understand that the PCT looks like it's involved because of what her urine studies are showing. Number 7, a 76-year-old woman is brought to the physician by her son, who is concerned that she has become more forgetful during the past few months. He thinks she should be placed in a long-term care facility. She says she feels well, thinks that her son is overly concerned, and clearly does not want to leave her apartment. She has no medical problems and appears cheerful. Which of the following findings is most crucial in determining her decision-making capacity? And then you look at all your answer choices. Now, questions like this can often be confusing, and different students might feel like another answer seemed more plausible. So if we look at all these, she can write a sentence. Well, being able to write a sentence doesn't really show that she has decision-making capacity. She correctly identifies political leaders. That just shows memory, but not decision-making capacity. She expresses clear and consistent values, things that matter to her. That is decision-making capacity. She follows simple written commands. A lot of students thought that actually shows decision-making capacity, but it does not. And she has memory of childhood events. Again, that's also just memory. So people were kind of torn between C and D, and it's a difficult thing to pick, but I think it's pretty clear that it's C, but I can see how people can convince themselves into thinking that it's actually D. So if we go back to ethics, and let me see. Yeah, decision-making capacity. So this topic is actually discussed right here, and there's a couple things that are pretty important. So all of these bullet points are pretty much, any one of these would have been the correct answer for your question right there. And our correct answer was this one. See, values and goals. Decision is consistent with patient's values and goals. She is supposed to have values and goals, and she does. She has values, which is what's going to help her make her decision of staying home. Right? Maybe she values her independence, and she doesn't want to be at a facility. Right? Patient has to be informed. So remember, for all decision-making questions, make sure that the patient knows and understands. Right? So if they don't understand what you're talking about, that's not decision-making capacity. Right? The patient expresses a choice. They have to actively and expressively tell you, this is what I want. I want to stay home. I want to get the surgery done. I do not want to get the surgery done, etc., etc. Decision is not a result of altered mental status, so make sure that the patient is not delirious, which can happen, especially with aging. Right? The patient obviously should not be intoxicated, and one of the more difficult ones, the patient should not have any kind of mood disorder. Right? So make sure the patient is not exhibiting a mood disorder. And of course, the decision should remain stable. If they're very, iffy about their decision, then that is not a decision. That is you kind of thinking about it. Right? And the age thing is whatever, but patient is more than 18 years of age. But it really depends on what topic you're making a decision about. Number 8, a 45-year-old woman is scheduled to undergo a lymph node biopsy under local anesthesia. A surgical resident asks a third-year medical student to get signed consent from the patient before the procedure is performed. Which of the following actions by the student is most appropriate? So, if you've got to get informed consent, and this is a scenario. I'm guessing it must happen pretty often because I've seen so many questions on this. So this is a scenario that you can expect will happen to you too. And if you're upperclassman, or if you're surgical resident, or you're attending, asks you to go get informed consent, the only way you can go get informed consent is if you know everything about the procedure that's about to be done. Right? And the procedure that's about to be done here is lymph node biopsy under local anesthesia. It's not a very difficult procedure. However, this resident might not know everything about that procedure. So that's why the correct answer here was, and they didn't make the answer choices too confusing. The correct answer here was accompany the resident while the resident obtains signed consent. Right? So you don't go do it yourself. So even though the resident told you to go get the signed consent, you won't do it. You'll tell the surgical resident, it'd probably be better if we both went together. I don't know everything about this procedure. That's it. Straightforward. Other answer choices were get the signed consent from the patient, get signed consent from the patient with another medical student acting as a witness, or refuse to obtain signed consent. Now, C and D don't make any sense whatsoever, so the only other answer choice you could have possibly picked was B. But most questions about this kind of stuff, where you're a third-year medical student and you're working with the resident, and the resident asks you to do something really important, you don't do it. Keep in mind that you're actually a third-year medical student here. You yourself are not even a resident yet, right? It's not like you're a resident and your attending asks you to do something. You're just a medical student. So that's what's kind of implying that even though this procedure is not that crazy, it's just a lymph node biopsy. It's not that crazy. As a third-year medical student, you might not actually know everything about how this procedure is done within the clinical setting, right? This question would be different if the question said, your attending physician asks you, and you are a third-year resident, to go get informed consent for this procedure. Then you would just go get the signed consent from the patient, because you should know how this procedure works as a third-year medical resident. Right? So that's where this question was unique. It's a third-year medical student, and as a medical student, you don't really do much besides just watch. Number 9, a study was conducted to investigate the mean age at onset in one type of muscular dystrophy. Based on a mental evaluation, patients were divided into 2 groups: normal intelligence and subnormal intelligence. Okay, that's kind of mean. The results are given in the table. So you look at your table, you have your age at onset, the average, and the standard deviation. Okay, if age at onset has a normal Gaussian distribution, the percentage of children with normal intelligence who will have onset of the disease at less than 9 years of age is closest to which of the following? Right, so this is just a question about statistical distribution, and you should feel very confident when you have to think about the Gaussian curve, right? So, wait, that did not start off right. So when you think about the Gaussian curve, you look at this thing right here, right? And usually you want to break it down from the middle and just divide it up and put the percentages in there, right? Because first aid kind of teaches you that this whole thing here is 68%, but you really want to break it up. You want to put the 34 in here, the 34 in here, and the difference between the two sides is the +1 standard deviation, -1 standard deviation, +2 standard deviations, right? -2 standard deviations, and so on and so on. So for this question, they've given you the standard deviation, they've given you the mean, right? This number here is supposed to be the mean, and then age at onset in years. So they're concerned with if age at onset, percentage of normal intelligence. So they're concerned with this first one. Who will have an onset of disease at less than 9 years? Less than 9 years. Okay. So look at the explanation now. In a normal Gaussian distribution, mean equals mode equals median, which is why the graph looks like this. And here, that is 3.8. Right? So the middle number here is 3.8. For disease at an age under 9, pretty much encompasses everyone. So 99%. The middle is 3.8 for your mean or the Gaussian curve. Plus or minus 1 standard deviation is 2 and 5.6. Right? So you would go in both directions. So this way it would be 2, this way it would be 5.6 in 1 standard deviation. Then you do another plus or minus 1 more standard deviation. You go this way again, that would be 0.2. Here it would be 7.4. And you do it one last time, you basically hit 0 over here, and you hit 9.2 over here, which is this tiny area under here, right? So now we've hit 3 standard deviations basically, and 3 standard deviations, if you do 3 standard deviations of your statistical distribution, you're basically covering the whole map, the whole curve, okay? So that's why the answer was 99%. That's it, right? And the more you do questions like this, the more you practice stuff like this, the easier it will become for you. It really isn't as bad as you might think it looks, alright? It's just, it takes time to master. It definitely takes time to get good at it. But if you do a lot of questions like this, you start seeing the fact that, in this question, for example, they told you that, this age at onset over here is 36. It's just such a big number, right? But they wanted you to just find someone at 9. 9 is so far away from 36, so you would have to encompass everyone to get that, right? Or you could even work with the mean. Look, the mean is 3.8, right? And standard deviation is 2. So if you need to get to 9, you have to keep adding 2, keep adding 2, keep adding 2 until you hit 9. That's what we did in our question, right? And when you do that, you realize you're adding 3 standard deviations, and adding 3 standard deviations pretty much covers the entire curve, right? So when you go take your step 1, when you go for your NBME, whatever test you have to take, make sure that on your cheat sheet that we've been preparing since the first day I started the first day 2019 playlist, that you're able to put this there, this entire thing. You should be able to put it there, right? So you're going to draw this curve on some edge of your paper, put the plus or minus ones and 68, 95, 99.7. Or you'll actually write inside, right? So this first one here is 34, this one here is 13, and this is 2. Okay, so all of that adds up to give you the about 50% on this side, 50% on that side. And that's how you get questions. So you could tell that our question involved this, right? Because we're doing plus or minus 3 standard deviations, you cover a lot of the graph, right? Pretty much all of the graph. All right, so don't get weirded out, don't get intimidated when you get a question like this. You're just working with basic numbers, and this was a very nice question. It was a very nice question. You didn't even need to worry about anything. Just take the numbers you care about. You care about the mean, you care about the standard deviation, work with it, solve it. Number 10, a 24-year-old man has a grade 3 out of 6 systolic murmur. Cardiac catheterization shows. Okay, so right atrial pressure is 6, right ventricular pressure is 30, pulmonary artery 30, left ventricular pressure is 180, aorta is 110. Okay, so everything was falling into place correctly. Keep in mind, right, the way to solve questions like this, I mean, there's many ways to solve questions like this. One way would be to obviously remember the numbers, but who does that, right? Who remembers the numbers? That's not so easy. So you could draw the ventricles of your heart, first things, right? And you draw the aorta, okay? So the ventricles of the heart, and you draw the aorta. And you should understand that when blood is coming in from anywhere to another part, right? Anywhere from one part to another part, that the pressures should add up. For example, blood going from the right ventricle into the pulmonary artery should have the same pressure, right? Blood coming from your pulmonary vein into your left atrium, they didn't give you that stuff, but they tell you left atrial pressure is 10, which is actually okay, because left atrial pressure is not supposed to be that high, right? Then you have your left ventricle. In your left ventricle, you're supposed to have high pressure. That also makes sense because it's like pumping against your entire body. But look at that. That 180 pressure did not get transmitted into the aorta, right? When your left ventricle contracts, that's when you're going to have a systolic murmur, right? Systole is contraction of your ventricles. And when your left ventricle contracts, this is your left ventricle here. This was the aorta in my ugly picture. When your left ventricle contracts, all the blood going from your left ventricle goes into the aorta because the aortic valve has now opened up. If your aortic valve opened up, the pressures should equalize in this entire path. But it looks like his aortic valve didn't open up, and then you look at all your answer choices, and the easiest one to pick immediately is just aortic stenosis. That's it, right? Keep in mind the mnemonic I made when we did cardiology, D-arms, right? D-arms. D-arms was diastolic is aortic regurgitation and mitral stenosis. Those two guys are your diastolic murmurs. So if you had aortic regurgitation or mitral stenosis as answer choices here, you would cancel those out immediately. You don't have those answer choices here, so it's whatever. And then looking at all your other answer choices, you would have to try to find a way to prove them. Where would these other answer choices kind of make sense? And there can be pressure and oxygen saturation issues where these other answer choices would make sense. For example, if you have an atrial septal defect, right, then in your left atria and your right atria, there's a big difference in oxygen saturation. Left atria has more oxygen, right atria has no oxygen. If there's a septal defect, though, all that deoxygenated blood in the right atrium would go into the left atrium, and your oxygen saturation in the left atrium would be low. But the left atrium oxygen saturation is perfect. Okay, so it could not be ASD. Mitral regurgitation didn't make sense here either because the pressures are not showing you that. Pulmonic stenosis would basically show you here a difference in pressure, right? So the right ventricle would be 30, but the pulmonary artery would be like 5. Just like we have aortic stenosis, where the left ventricle is 180, but the aorta is not 180. It should have been 180 also. So if we go to page 313, you kind of see the numbers that the book gives you. And this is what I was talking about, right? So your pressures should be the same everywhere. So you see how when it's 130 here, it's 130 in the aorta also during systole, right? But the pressures are very different during diastole. When the left ventricle is filling, pressure is super low in there. But when your aortic valve closes, pressure is still very high in the aorta, 90, because all that blood kind of comes back and smashes into the closed aortic valve. That's also when you give blood into your coronary arteries to supply your own heart with blood, right? And a lot of other stuff happens. You can also see these pressures are matching, right? This is 25, so then that's also 25. Okay, and then in your left atrium, it should be less than 12. A lot of these numbers, you don't need to memorize the numbers specifically, but you should have a very good understanding of them. Number 11. A 33-year-old woman comes to the physician for a routine follow-up exam. She has celiac sprue and fat malabsorption. Okay, physical exam shows asthenia. Lab studies show a serum calcium concentration of 7.8. Which of the following additional sets of serum findings is most likely in this patient? So you're looking at inorganic phosphorus, parathyroid hormone, and calcitriol. Okay, she has celiac sprue and fat malabsorption. If you have fat malabsorption, you're not going to absorb fat-soluble vitamins, one of which is vitamin D. So this patient would have low vitamin D. Okay. Now, with low vitamin D, you can also assume you're going to have low calcium. So if you have low calcium, you're going to have high PTH. We finally found something that has that, right? E is one of them. E is one of the answer choices where you have low calcium and high PTH. But let me see. The other case scenario is A, right? A also has low calcium and high PTH. So now it's down to phosphorus. Well, anytime you have high PTH in a physiological manner, PTH is phosphate trashing hormones, so phosphorus should be low. Okay, we had a similar thing yesterday for a patient who had chronic kidney disease, but there was a trick. In chronic kidney disease, your PTH would be high, right? Your PTH would be high, but your phosphorus would also be high. Even though you have phosphate trashing hormone, you're unable to trash the phosphate because your kidney isn't working. Okay, always keep that in mind. That was one of the questions we did yesterday. And calcium would obviously definitely be low because you're losing the calcium in your kidney. So chronic renal failure is where you have answer choice A. Alright, always remember that. Anytime you have a question where a patient is presenting with high PTH and high phosphate, that means that the PTH is not able to do its job, and it does its job at the kidney. That means that the patient must have renal failure. Alright, so always keep that in mind. Number 12. I don't want anyone to ever get this question wrong. This one is, you solve this question by remembering that I pray that Theo can breathe again. And Theo is Spanish for uncle. Okay, so here they tell you a 74-year-old woman comes to the physician because of a 3-month history of progressive shortness of breath with exertion. Her symptoms are not exacerbated by lying down, which means it's not heart failure. She has smoked 1 pack of cigarettes daily for 56 years. She is seated with her hands placed on her knees using accessory muscles of respiration. Her temperature is 99 Fahrenheit, pulse is 88, respiration is 17. Physical exam shows no JVD because, again, it's not heart failure. Chest exam shows an increased anteroposterior diameter, which kind of makes you think of emphysema. Where was I? Oh, and breath sounds are decreased and heart sounds are distant on auscultation of the chest. No peripheral edema. In addition to albuterol, which of the following is the most appropriate pharmacotherapy for this patient? And you have acetylcysteine. Acetylcysteine would be something you would give to someone with cystic fibrosis. It's a mucolytic. Amantadine, right? Cromolyn sodium, montelukast. Cromolyn sodium and montelukast are also medications you can use for asthma. Amantadine was actually a medication in microbiology, I think for influenza or something. So that doesn't fit here either. She doesn't have influenza. So the answer here was D. Why? Ipratropium competitively blocks muscarinic receptors, preventing bronchoconstriction. Cromolyn is rarely used and prevents mast cell degeneration. Montelukast and zafirlukast block leukotriene synthesis for anyone who has aspirin-induced or exercise-induced asthma. A and B are unrelated to asthma. Alright, so you would not pick cromolyn sodium or montelukast. Cromolyn sodium is actually more so for people who have allergic stuff. So, the preventing mast cell degranulation or degeneration is really important in them. Montelukast and zafirlukast, remember yesterday we did a question on NSAID-induced asthma, where because you're taking a COX inhibitor, all of your arachidonic acid no longer goes towards the COX stuff, so it goes into leukotriene synthesis, and when you make leukotrienes C, D, and E, when you make those leukotrienes, those guys actually cause bronchoconstriction, leading to NSAID-induced respiratory disease, right? The NERD thing. So in those patients, you give them montelukast and zafirlukast. That way, not only do you block the COX stuff, you also block the leukotriene stuff. So all your arachidonic acid will not be going in either direction. Irrelevant to this patient, right? So always remember, I pray that Theo can breathe again. Ipratropium is discussed in many places. Let me see, this is 763. So in 763, that's the respiratory chapter. They talk about respiratory physiology. You look at all your asthma drugs. And where is it? Right here. Muscarinic antagonist. Theotropium, ipratropium. So remember when I said I pray that Theo can breathe again? I pray is Ipra and Theo is your uncle. Okay? Thea also works obviously because our patient was a female. Competitively block muscarinic receptors, preventing bronchoconstriction, and also used for COPD, which is why you would give it to this patient. Our patient, when they tell you the increased anteroposterior diameter, that's a really big barrel chest. That's emphysema. That's part of COPD. Use ipratropium. Okay. Number 13. The image here is for 14, but we're looking at 13. 13, a 16-year-old girl is brought to the emergency department 30 minutes after being injured in a motor vehicle collision. Her blood pressure is 70/40. Physical exam shows cold, clammy skin. Chest x-ray shows a fracture of the 9th rib on the left. An exploratory operation shows a rupture of the spleen. Ligation of the blood supply to the spleen is most likely to damage which of the following additional structures? So this is related to GIT, which, remember I said yesterday that if I had to rank the easiest chapters or easiest systems of first aid, then GIT is the number one easiest chapter of first aid. Second to that would be endocrine, and then after that the things get a lot harder, mostly because they're dense, like they're longer chapters. Like musculoskeletal is long, hem-onc is long, but they're not actually hard. Neurology is hard, respiratory is hard, and cardiovascular is the hardest. So here we're talking about the celiac trunk and one of those vessels. We're talking about the splenic artery. You need to remember what else the splenic artery supplied blood to. Right? And this one was a really nice question because a lot of students don't ever really tend to remember this part. I guess it's not the most high yield part, 394. I always keep looking at the wrong number. So if you look at this, right, you need to memorize this image. Like, it should be perfectly in your mind. You should also have this memorized, right? The actual breakdown of the vessels. So if we're currently looking at this one here. We're looking at the splenic artery. So you could see that the splenic artery, one, it gives this short gastric to this area of the stomach, right? It's this entire orangish area, this entire orange area, right? It also provides, as you could tell, to that portion of your pancreas, right? This is the left gastroepiploic artery. Everyone remembers the left gastroepiploic artery for supplying the left half of the greater curvature, but it's not just the left half of the greater curvature, it's also the tail of the pancreas, which you see in the back right there. Okay, so really important to make sure you remember that. That almost never gets tested, nor is it ever relevant in any question. And most cancers are usually of the head of the pancreas over here. So at that point, you can remember the pancreaticoduodenal arteries and stuff, right? But this one always everyone forgets. Tail of the pancreas is supplied by a branch of the splenic artery. mainly the left gastroepiploic. So that's what this question was about. So tail of the pancreas. In addition, the other answer choices just don't make any sense. Your ciliary trunk doesn't supply to any of those other guys, right? Except the horizontal duodenum, sort of, not really, but again, irrelevant to the splenic artery. In fact, ciliary trunk doesn't even get to the horizontal duodenum. The horizontal duodenum is this part here, and blood supply is only up to like the first and maybe second part of the duodenum. That's it. So the third part of the duodenum doesn't really get ciliary trunk blood supply. Down here, this is something that almost everyone has at some point had. 42-year-old woman comes to the office because of a 1-year history of an enlarging painless mass on her right wrist. Examination of the right wrist shows the findings in the photograph. The mass is firm and non-tender and transilluminates with the application of a pen light. Without treatment, which of the following is the most likely to occur in this patient? And everyone always falls for paresthesias. I further respect picking that answer choice because it is kind of in this area where you would imagine maybe it's going to cause carpal tunnel syndrome, right? And in all honesty, I do think it could cause carpal tunnel syndrome because of the placement of where this ganglion cyst is. Usually you would have a ganglion cyst like over here somewhere, maybe here, but when you have it right here, this can very well cause carpal tunnel syndrome. However, the correct answer for this was spontaneous regression. Ganglion cysts eventually go away. Okay, so it's really important to make sure you know that. Page 505 talks about it in musculoskeletal. Right, so you can see here again, fluid-filled cyst or ganglion cyst. Right, fluid-filled swelling overlying joint or tendon sheath, most commonly at the dorsal side of the wrist, arises from herniation of dense connective tissue, and it goes away by itself. Okay. Also, it's not a ganglion. It's not a collection of nerves or anything, or neurons. 15, they gave you this image of the cavernous sinus. 44-year-old man was brought to the emergency department by police 45 minutes after he sustained injuries in a bar fight. There are multiple facial fractures and contusions, including a severely swollen right eye. So we're focusing on the right eye, okay? Right, so that's a really bad circle. So we're focusing on the right eye. Complete physical exam cannot be done because of facial edema. He refuses to try to open his eye because when he does, he has double vision. A CT scan of the head is done and a coronal image through the midface is shown. Which of the following is the most likely explanation for this patient's visual complaint? So you look at it and you can tell that, in this right eye, there's obviously a difference between the right and left. There seems to be some kind of issue here at the bottom, right, and over here as well, both. Okay, both of those seem to be kind of a problem. Here, there's something, but I don't know how significant that one is. So now you look at it, avulsion of the optic nerve, dislocated optic lens. Those two you can definitely cancel out. The optic nerve is behind. It's deep in the eye. That's not going to be, avulsion of the optic nerve would just cause blindness, not double vision or anything. Dislocated optic lens. That's, although his optic lens could get dislocated, it doesn't seem to be, I find this to be a weird answer choice. Actually, it's kind of hard to debunk, but it doesn't really seem to be what's actually happening to him. Again, they tell you here, right? They tell you that he refuses to open his eyes. When he does, he has double vision. And a dislocated optic lens, maybe it can cause double vision. I'm sure it does, but that's not what we're supposed to pick, apparently, right? The only reason I wouldn't pick this answer choice is because it's usually not an actual answer. I've never seen a question where the answer was a dislocated optic lens. D says free blood within the anterior chamber. Again, you could have free blood in the anterior chamber. However, that would not cause double vision. The globe is pierced by bone fragment or injury to the optic tract posterior to the chiasm. Again, this thing, F and A, are both talking about the same thing. So both of those are wrong answers. So you're really kind of in between, let's say B, C, and E, right? So this is the cavernous sinus. Many people felt it was E because of the air in the center of the eye, right? This air right here. But even if that were the case, it does not explain the double vision. In fact, none of the choices besides C explain double vision. And that's just the truth of the matter. No answer choice here would actually lead to double vision. But if you have entrapment of the inferior rectus, that can cause double vision, right? And these 3 places that I marked X, the inferior rectus could actually have gotten entrapped in this lower one over here. Right, so that's kind of how you have to tackle this question. I won't argue the fact that it's definitely got a bullshit list of answer choices, but that is what it is. 16. Okay, 16 was pretty easy. Investigator is conducting a study to determine the cause of an outbreak of illness at a skilled nursing care facility. A total of 13 residents developed fever and erythematous rash and varying degrees of renal impairment during a 2-week period. A previously unidentified virus is recovered from urine specimens collected from 7 of these patients. Physical characterization of the virus shows that viral infectivity is essentially destroyed by heating, right? Heating 60 degrees Celsius for 30 minutes. Based on this finding, the virus most likely has which of the characteristics. It's enveloped. That's it. Loss of the envelope, either by heating or use of any kind of solvents, will lead to a loss of viral infectivity because it will no longer be able to combine with our lipid membrane, so the genome will never enter our cells, okay? But if you have, if heating was just doing genome consisting of DNA, genome consisting of RNA, first of all, you can't, if you actually thought the answer might be B or C, how do you actually pick between B or C? You can't. There's no way to actually pick between B or C here. If either one of them is true, then both of them is true. And then at that point, both of them could be possible for this newly discovered virus. Capsid symmetry was just a dumb answer, and the non-enveloped wouldn't make sense either. So it's pretty straightforward. 167 talks about this in microbiology. Right? They tell you the first thing, as soon as we start talking about viruses, right, you have a naked virus with an icosahedral capsid. Right? Then you have an enveloped virus with an icosahedral capsid. So this same thing with an envelope over it basically gives you this image. Right? That's the envelope. And that envelope kind of combines with our lipid bilayer and allows that combination to kind of just throw that capsid into our cell, and then we take the DNA or RNA, whatever it is, and we use it as if it's our own genetic material. Our body uses it. But it's not our own genetic material, and we end up getting really sick. Okay. 17, the student got wrong, so let's take a look. 16-year-old girl with bulimia nervosa is brought to the physician by her mother because of a 4-month history of non-bloody diarrhea. Her mother is concerned that she is abusing laxatives to maintain a low body weight. The patient is 165 centimeters tall and weighs 52 kilograms. BMI is 19, temperature is 99.5, pulse is 120, respirations are 30, blood pressure is 89/60. Which of the following sets of serum electrolyte concentrations is most likely in this patient? So bulimia nervosa, right? She's been having a lot of non-bloody diarrhea because of using laxatives. So all that we really care about is she's having diarrhea. She's losing something in her diarrhea. Look at all your answer choices, and essentially you're thinking, most things that are going to be decreased are most likely going to be the potassium and the bicarbonate. And for that, you really just have, wow, there's only one answer choice where potassium and bicarbonate are low. That's it, just D. And you need to remember that. That's something you need to know. With excessive diarrhea, potassium and bicarbonate are always going to be low. You lose potassium, you lose bicarbonate, you're kind of just shitting it all out of you. So they were nice to you here. D is the only answer choice where potassium and bicarbonate are low, and chloride would be high. So the explanation I wrote, acid-base laxative use is similar to having diarrhea, which causes a normal anion gap metabolic acidosis. You would have hyperchloremia, Addison, RTA, diarrhea, acetazolamide, spironolactone, and saline are all under hard as. And if you remember the hard as mnemonic, then hyperchloremia would remind you that chloride would be high. Not entirely sure where to find all the details of ions and pH for laxative abuse. ASN Journals describes the laxative abuse causes hypokalemia, which raises the extracellular bicarbonate so your cells lose bicarb. And only choice D has both things low. Okay, but I couldn't really find major information on laxative abuse online. Regardless, diarrhea and laxative abuse are pretty similar, and you need to remember the mud piles and the hard ass stuff from your acid-base things. So acid base is in renal. Right, so you have your mud pile stuff and you have your hard ass stuff. Alright. And hard ass is the one with the normal anion gap, and one of the things are hyperchloremia. Alright. But then there's also diarrhea here. Okay. So this diarrhea stuff is very much the same with laxative abuse. All of that. Right? And in this scenario here, this is under metabolic acidosis. Acidosis means your bicarb will be low, and when you think of bicarb being low, you're really down to just 3 acid choices. And if you remember the hyperchloremia because of hard ass, then the only one you're down to now is these 2, and you still would not be able to answer it. You would have to remember the potassium thing. I don't know how you would know though. To be entirely honest, I don't know how you would know, because in hard as, the only other thing, I guess if you remember hard as, you can answer it. That's how I answered it, because all of these guys in hard as share the same thing. They all share the same thing, same presentation. So hyperchloremia told me that chloride would be high, and remember Addison, right? Remember Addison. I put it right here. Addison is adrenal insufficiency. You lose sodium, and you keep potassium and H+. Keeping H+ means losing bicarbonate. Losing bicarbonate means keeping chloride, right? Because of the basolateral bicarb chloride exchanger found in the PCT. So you end up having low sodium and bicarb and high potassium chloride and H. However, right, this anion gap, right, the giveaway for the anion gap is to pick decreased potassium. You just have to memorize it. You just have to memorize it. It's really no other way to answer this question. I don't blame this student for getting it wrong. I don't even know how to explain that you would know this thing perfectly. If anyone else has a better explanation, definitely bring it up. But I do know that you have to memorize it. You definitely need to remember that if anyone has diarrhea or has laxative abuse, that you lose your potassium when you poop, right? And way back in med school, I remember this as people always tell you when you have constipation to eat bananas. Bananas are high in potassium. And I just told myself, okay, so basically the potassium is going to help me shit, and I'm going to shit the potassium out, So that's how I always remember this. When I saw this question, I just told that same story to the student too. Told him that anytime you have diarrhea or laxative abuse, you lose potassium, you lose bicarb, and you're going to have high chloride levels, right? Because chloride, you lose chloride more when you start thinking of vomit, right? When you vomit, that's where you kind of lose chloride, but not in excessive diarrhea. 18, a 44-year-old woman comes to the physician because of steatorrhea, flatulence, and 22-pound weight loss over the past 6 months. So that's a really long time. Findings on exam are unremarkable. Lab studies show low hemoglobin, microcytic anemia, iron not looking too good either. Iron not looking too good either. Test of stool for occult blood is negative. Stool cultures and stool exam for parasites are negative. A lateral x-ray of the chest shows mild osteopenia. Okay, which of the following is the most likely explanation for these findings? So you look at all your answer choices. They don't have iron deficiency anemia here, but it doesn't matter because iron deficiency anemia is not necessarily what causes steatorrhea or flatulence anyway. So you're looking for an answer choice that causes fatty diarrhea, right? Steatorrhea. So of all of these answer choices, atrophic gastritis, bacterial overgrowth. Again, bacterial overgrowth kind of didn't make sense because they kind of told you stool cultures are negative, so you can cancel out B. Atrophic gastritis is just, it's really bad inflammation. This would have possible blood, so they told you there's no blood. Intestinal pseudo-obstruction. Irritable bowel syndrome, IBS. Irritable bowel syndrome is more of a psychological thing where you alternate between diarrhea and constipation regularly. You would not have steatorrhea. Same thing with pseudo-obstruction. And obstruction would not cause steatorrhea and flatulence. So the only answer choice here that you could pick that causes steatorrhea and flatulence is celiac sprue. Celiac disease or celiac sprue, which is a tropical sprue, right? Either one of those can cause you to have flatulence. So if we go back to page 412 in GIT, right, which is one of the easiest chapters, celiac sprue isn't just celiac disease. It's actually this one here, tropical sprue. Similar findings as celiac sprue. affects small bowel but responds to antibiotics. Cause is unknown but seen in residents of or recent visitors to tropics. You would end up having decreased mucosal absorption affecting the duodenum and jejunum but can involve the ileum with time. Associated with megaloblastic anemia due to folate deficiency and later B12 deficiency. But our patient had iron deficiency anemia, which was really just a scenario there to kind of try to throw you off. This could be iron deficiency anemia. This could also be anemia of chronic disease because she's had this issue for 6 months and she's losing weight. Either way, the giveaway stuff was steatorrhea and flatulence, of which the only answer choice that can cause is celiac sprue. Alright. 19. A 61-year-old woman comes to the physician for a health maintenance exam. She says that she has been feeling well. A split S1 is heard over the left sternal border. So this is a question about splitting. Which of the following best explains the first component of this sound? So first of all, heart sounds are from closure, not opening. Right? So you can immediately cancel out all of these. Right? That was something that a lot of medical students that I worked with for this question didn't really remember. Right? So all your heart sounds are from closing of valves, not because they opened. So you cancel out 50% of your choices. Right now you're down to 4 answer choices, drastically increasing your chances of guessing correctly. Right? So now you're down to a 25% chance of guessing correctly. S1 is from the closure of mitral and tricuspid valves, right? Whereas S2 is the aortic and pulmonic valves. So this must be the mitral valve. That's it. You would not pick the pulmonic valve here. This has to be the mitral valve. Why? Because nothing ever actually gets wrong with the pulmonic valve. Unless you have pulmonary hypertension or something, it's very rare. But mitral valve, everyone's mitral valve gets issues eventually, right? Also because they describe the left sternal border. So, this actually, to be entirely honest, left sternal border, if you go with the APTM mnemonic, a lot of people wanted to pick closure of pulmonic valve because they said the left sternal border, but that's not what's happening here, right? We're talking about splitting. If we go back to first aid, you'll see what I'm talking about. Hold on, let me just page 302. So this page first gives you what all the splitting stuff is, right? So you should know everything here really well. You should always remember that S2 was about aortic and pulmonic, right? And S2 was, that's the other, sorry, that's why you would never pick that, right? Because they tell you it's a splitting of S2. S1 is for your mitral and tricuspid. So what I'm actually trying to help you with is figuring out why not tricuspid, and not tricuspid because APTM, right? The tricuspid is further down. But other students did want to pick pulmonic because of the whole aspect of just not even remembering splitting. You need to remember S2 is aortic and pulmonic, and that's what we're actually examining in each of these scenarios. We're examining the pulmonic stuff, right? The fact that there's a difference in how long it takes for the pulmonic valve to close based off of whether you're breathing in or breathing out, or if there's something wrong with you, right? Especially in the paradoxical splitting, where I made my own lines to kind of show you what happens and how things look different. Right, so now you can see how the correct way, right? Remember that, look at all of these other places. The blue line, then is the red line. Pulmonic is after aortic. When paradoxical splitting, pulmonic closes quicker, right? And that's usually because you have an issue with that aortic valve. The aortic valve did not work correctly, all right? So it took too long to close, so long that the pulmonic closed first. But in this question, there really should not have been any reason to get it wrong. This student got it right too. It was pretty straightforward. Just make sure you know the basics of splitting. Splitting is one of the easier things in cardiovascular. It's not a difficult topic to understand. 20, also not that bad either. Just a straightforward biostatistics question. In a study of the use of ultrasonography from the early detection of prostate cancer, not biostatistics, epidemiology, I mean. 35 of 50 men with prostate cancer have abnormal test results, and 20 of 100 men without prostate cancer have abnormal test results. So they're talking about all the false test results. Which of the following best represents the specificity of this test? So now you should make that, that 2x2 column and just fill it in. Or you could just plug things back into the equation if you remember it, which should be on your cheat sheet. Specificity is true negative over true negative plus false positives. This test gives 20 false positives out of the 100 people and only 15 true negatives out of 50 men, right? Because remember, they told you all the false answers. So here, this one told you that 15 were correctly identified, right? Correctly identified. So that was your true negative, okay? 35 of 50 men with prostate cancer have abnormal test results, but 15 of 50 men with prostate cancer had correct test results. All right, and then 20 of 100 men without prostate cancer have abnormal test results. So that 20 out of 100 was your false positive, straightforward. And then you could just plug it in and you would finish it. You'd be done. The other way to do it was using this other equation. Specificity is equal to 1 minus your false positive rate. And the false positive rate here is 20%. So 100 minus 20% is 80%. Two different ways to solve it. Both of these equations are just straightforward ways of solving specificity. And when we made that cheat sheet we put these equations on the top right there. So you're not supposed to memorize it or anything like that. When you sit down for your test, you just write all these equations down. And I guess 3 to 4 days before your test, all you're really going to be doing is practicing rewriting that entire cheat sheet for yourself. So you can not only just memorize it, but once you sit down, you feel that confidence boost. Once you have the equations there, there's a bit of that confidence boost that all the students I've had kind of tried this out really enjoyed. And it works out. When you do your NBMEs, you should do it too. And on your regular days of studying, also utilize it. Same thing. But every time, every single day, rewrite it. Don't use the same sheet over again. Number 21, a man accidentally touches the surface of a hot stove. 20 minutes later, a blister develops at the site. Biochemical analysis of the blister fluid at this time is most likely to show the presence of which of the following. And this is just a blister. This is something that's happened to almost all of us. It's just histamine. There's nothing crazy, no immunological things happening here. It was a very straightforward question, but I think every student I did this with was able to get it correctly, actually. Yeah, but I can imagine someone, overthinking and then trying to go for like interleukin 1 or 2. But those guys are directly related to many different things, right? Interleukin 1 is for fever. Interleukin 2 is related to T-cell differentiation. You need to remember all of that from hot T-bone steak, right? Gamma interferon and IgE don't even have anything to do with the blister in this kind of scenario. So it was just histamine. 22. Investigators conduct a prospective, community-based study to assess the effectiveness of an intervention to promote early language acquisition among children during the first 3 years of life. So we're basically trying to get kids to learn language quicker. Delivered over 6 months across 5 daycare centers, the intervention consisted of providing monthly classes to a cohort of mothers beginning when each child was 2 years of age. Wow, they made that sentence so complicated. So this is going to happen for 6 months across 5 days. This is going to happen for 6 months across 5 daycare centers, and they're going to be working with mothers whose child is at least 2 years by now. Each child's language skills were assessed independently at the ages of 2 and 3 years. Scores were normalized for age, and the results are summarized as follows. So now you're looking at the number of class sessions attended by the mother and the mean change in child language score, how much child language you've been able to instill by the age of 3. And they gave a standard deviation with it. Okay, which of the following sets of characteristics of this study best supports a causal relationship between the intervention and the child language scores? Okay, so we're basically, this is a question about figuring out whether something just happened because it just happened, or you're looking at cause versus effect, and whether or not something actually caused things to improve. So if we look at all our answer choices, they're divided into 2 sections. The first 3 answer choices are dose response gradients, and the next 3 answer choices are strength of association, both of which are concepts that are not discussed in first aid, right? So you would have to look it up somewhere. And the student that did this question, they chose strength of association, specificity, and sensitivity. So basically, all you need to do for this question is figure out which one of these answer choices helps you understand something caused something to occur, right? This entire investigation actually occurred over a time span of age 2 to age 3. So it occurred over a whole year. And in that year of time, language was supposed to get better. Not only that, but some mothers only attended 1 class session, whereas some mothers attended 6 class sessions. And it's clear that the mothers who attended 6 class sessions, their child had much better understanding of language than the one whose mother only attended 1. Right? So there's definitely some kind of causal relationship here. How am I going to show that? The correct answer for this one was strength of association, temporal relationship, the fact that being in more sessions showed a better improvement in language, and dose response gradient, same thing again, more sessions, better improvement, right? Specificity and sensitivity do not establish causality, right? Those are not things you use to calculate causality in a graph or whatever. And then consistency of other studies was irrelevant. There were no other studies. So you can knock out D and E. And then if you look at A, B, and C, dose response gradient makes sense. That's okay. But then again, specificity does not help you establish causality. Specificity does not help you establish causality, and sensitivity doesn't help you establish causality. Those are the only ways you would cancel out A, B, and C. So you see how, even though this was a question that I have never really faced before, and I didn't really know anything about dose response gradient or strength of association per se, these are words that you can kind of, define. They're not weird words that you would have to know the definition of. Like, for example, the word narcolepsy doesn't mean anything if you don't know the definition. But here, strength of association means something. Dose response gradient means something. And both of those are correct. But when you look at the whole answer choice as a set, that's when you can knock things out. And in A, B, and C, they keep repeating specificity and sensitivity. So you just knock those out. Same thing here, you knock this out for the same reason. Specificity and sensitivity are used for diagnostic tests, not to establish causality. So that's the whole concept of how you would tackle this kind of question. Weird question, but this is pretty common of NBME to ask something like this out of nowhere and just try to catch you off guard. So don't fall for it. 23, so I'm going to do 23, 24, and 25. Go get lunch, come back, and finish the rest of this block. 23, a 44-year-old man who is a farmer and has been spraying his orchards with insecticides is brought to the emergency department by his wife because of vomiting, diarrhea, wheezing, and sweating for the past 12 hours. So this is a very obvious question about the whole farmers and insecticides. He has excess salivation and generalized muscle weakness, is confused, and pupils are constricted. A drug acting at which of the following labeled sites is most appropriate for stabilization of this patient's airway? They only want to know the airway stuff. So then they gave you 2 different types. They gave you the adrenergic receptors and a muscarinic receptor. And the first thing you need to understand is that this is a muscarinic thing, right? You're going to be using autonomic drugs, and the only possible answers here for this patient would be between C or D, right? You can automatically forget about A, B, and E. This has nothing to do with the dopamine and norepinephrine stuff, right? It's not related to that. This is related to acetylcholine. And the patient has organophosphate poisoning, as evident from his very classical presentation, and the only way to fix this would to give him atropine. Right? Atropine is a muscarinic medication that would really help him by just by blocking that spot right there. And then all that excess acetylcholine will not be working anymore, and he's not going to have bronchoconstriction. So if we go to page 245, just take a look at that. Organophosphate poisoning is highly comparable to its exact opposite. Let me see. Yeah, this one right here, right? Anticholinesterase poisoning. Right? Often due to organophosphates like parathion that irreversibly inhibit acetylcholinesterase. Right? So this is exactly how the patient was presenting. Fluid coming out of everywhere, right? Excess salivation, tearing, diarrhea, urination, blah, blah. Fluid is just coming out of everywhere. That's organophosphate poisoning. The opposite of that is when you have, where's the other topic? Atropine overdose, right? When you have atropine overdose, then you're dry as heck. Everything is dry, right? So because you're so dry, you end up overheating. You have your pupillary dilation, so you become blind, right? Blind because too much light is entering the eye. and everything else full as a flask, because you don't have urination. All the urine is actually still in the person's bladder, urinary retention. Whereas the two completely opposite scenarios. But atropine causes bronchodilation, right? So that would be something that can actually be used to help this patient, right? So this is how you'll solve that kind of stuff. Number 24, 3-day-old female newborn delivered at term is brought to the emergency department by her mother because of a 4-hour history of yellowing of the eyes. Pregnancy and delivery were uncomplicated. The newborn has been breastfed. Okay, physical exam shows jaundice. Serum studies show a total bilirubin concentration of 14.5. So that's a little higher than normal. Newborn is placed in an incubator equipped for phototherapy. Which of the following best describes the mechanism of the underlying phototherapy? So this was something I always talk about. This baby is just presenting with physiological neonatal jaundice, and the phototherapy causes increased conversion of the bilirubin to water-soluble isomers, right? So basically it'll help you do the conjugation. This is something that was discovered by mistake by a bunch of nurses who had to shift all the newborns outside because of, I think, some kind of emergency inside the hospital at some one event a long time ago. And a lot of them that had physiological neonatal jaundice, they started getting better, right? So that was actually discovered by mistake, and then they started actually using that because it works, right? So the baby has immature UDP glucuronosyltransferase, so she has high unconjugated bilirubin, which is insoluble, right? And that's why she's presenting with jaundice. Phototherapy isomerizes the unconjugated bilirubin to a water-soluble form, and it helps them. That's a really straightforward question. Last one here, number 25. Last question here, 25. A 15-year-old boy is brought to the physician for a well child examination. During the interview, he asked the physician if he would develop severe acne like his 18-year-old brother did at this age. He says, "It was awful. My parents took him to the doctor, but nothing helped. Then one day, it seemed to go away on its own." Physical exam shows mild, scattered, open and closed comedones, which are for acne. If this patient develops severe acne vulgaris that resolves spontaneously over the next 3 years, rapid increase in the secretion of which of the following substances will have been the most likely cause of this acne? And this one, you immediately just pick testosterone and move on. You know that grown-up adult men who abuse steroids for maybe muscle building or stuff like that, they also end up getting acne, right? So it was just testosterone. Androstenediol is not androstenedione, right? Completely different things. Androstenediol is a potent estrogen, but androstenedione would have been a correct answer that you could pick, right? But they would never put both answer choices though, right? So this one was testosterone, but it was really easy to fall for the diol. And diol, this diol thing is an estrogen. Really tricky bait. They just baited people into picking that answer choice, but you gotta do your best to not fall for that. So pretty silly stuff. And then that's it. So now from here on, I'll be right back. It's 1:50, so I'll be back by 2 p.m. to continue this and wrap this up for today. Which other topics other than respiratory are not yet done? The current FA playlist is only up to neurology. I'm up to the ophthalmology chapter. That's it. But if you need anything after neurology, the older videos are also FA 2019. The title might say FA 2018, but if you look at the PDF would say just like that, FA 2019. I'm using the 2019 PDF for all videos that are respiratory, renal, repros, and psych. Those are all 2019. But the only thing that's different in those videos as opposed to the new videos is that in the newer videos I have the amboss stuff, whereas the old ones do not. Alright, so hopefully if you do need the respiratory stuff and stuff like that, then you can just use the older videos. They have their own individual playlists. FA 2019 is all one long playlist that I can just give to any student who's preparing for step 1.